This is Dr. Robert Bates from the Concussion Center of Fitchburg. I am a 1985 graduate of Palmer College of Chiropractic, magna cum laude, after going to Clark University as a biology major. I then graduated in 1989 from the chiropractic neurology diplomate course and have taken many courses since then. I am going to discuss concussion in a 3 or 4 part series, and we will begin today to discuss what concussion actually is. We have all seen Will Smith and Aaron Hernandez and other shows on television which have some things that are not true, and I want to clarify what concussion actually is. According to the best literature, we now see about 1.6 to 3.8 million sports related concussions per year in the United States. And this is probably very underestimated. We also have a lot of other types of concussion with little kids falling and learning how to walk and falling on bicycles. We have a lot of concussion slips and falls, and a very large amount of concussion with automobile accident, which is very often not diagnosed. For the purposes of today's talk, we are going to use the definition from the Fifth International Consensus Statement on Concussion in Sport of 2017. Which states concussion is a brain injury that results from a traumatic blow to the head or body with subsequent force transmission to the head. Concussion is usually a functional rather than a structural injury to the brain. We have both direct damage and we have indirect damage. A type of direct damage would be the skull being penetrated, causing local brain damage, or the brain hitting the skull so hard there's local brain damage. But a lot of the damage we see, especially in mild traumatic brain injury, mild concussion, where the symptoms actually can be permanent as well, is an indirect damage where we have certain lobes of the brain moving in relation to other lobes, and we have tearing of individual axons and small groups of axons, which very often cannot be seen, and that's why the definition talks about functional rather than structural damage. However, there must be structural damage if we have functional change. We also see many different specialties treating concussion today, and the best literature shows that you really have to understand concussion very well and treat all of the aspects of it, which is very often not done. Presently, we see 6 phenotypes, clinical phenotypes, that are categorized approximately 1 week after concussion. The first is considered a cognitive fatigue type, which has the patient complaining of fatigue, tiring more easily, forgetfulness, poor memory, poor concentration, and taking longer to think. The second subtype is a vestibular type, where the patient has a feeling of dizziness and balance problems. The third type is an oculomotor type, where the patient will complain of blurred vision and double vision and other visual changes. We then have an anxiety mood subtype, which is the patient being irritable, easily angered, feeling depressed or tearful, feeling frustrated or impatient and restless. The post-traumatic migraine subtype, the patient complains of headache, noise sensitivity, upset by loud noise, nausea and or vomiting, light sensitivity, and being easily upset by bright light. The sixth subtype is a cervical subtype, where there is neck pain and neck stiffness, and especially when there's a sequential abnormality of neck movement with eye movement. We begin to realize that mild traumatic brain injury or concussion results in a constellation of physical, cognitive, visual, emotional, balance, and sleep-related disturbances They can be any combination of what I have just discussed, which makes the diagnosis and treatment a very complicated circumstance. The common signs of concussion include headache, dizziness, gait disturbance, nausea, vomiting, photophobia or phonophobia, meaning light or sound sensitivity, trouble focusing, fatigue, slowed mental processing, concentration deficits, memory impairment, irritability, and depression. There are also a lot of complaints now due to what we call dysautonomia, or damage to the autonomic nervous system, where you can have various abnormalities of blood pressure and pulse rate, with your body having an inability to control where blood should be pushed, that it needs to do very specifically. There are also many other types of dysautonomia where there are hormonal imbalances and other problems. Because there are hundreds of millions of separate nerve cells in the brain, no two concussions are the same, and it would be totally impossible to classify concussions as heterogeneous with one size fits all for diagnosis and treatment. And sadly, that is very often what happens in the facilities that treat concussion. So let's discuss what actually happens to the nerve cells with concussion. The focal injury to the brain by direct or indirect mechanisms causes individual nerve axons and groups of axons to be damaged, either by blunt trauma or a shear traction mechanism. Potassium leaves the cell, causing membranes to depolarize or fire more than they should. Excitatory amino acids and neurotransmitters are released because of the depolarization. Calcium and potassium freely flow in and out of the nerve cells, and calcium damages intracellular functions. There is reduced oxygen available, creating cellular hypoxia. The brain is forced into glycolytic metabolism to create energy and increases lactic acid. There is then a breakdown in the blood-brain barrier and more cell death occurs. Local inflammatory responses occur over 4 to 6 hours, and the inflammatory response can lead to diffuse injury through the large flood of neurotransmitters being released. Damage is not predictable due to all of the many variables involved. The shape of the person's skull, the way their brain is suspended in their skull, the size of portions or lobes of their brain, the amount of cerebrospinal fluid, and the exact acceleration, deceleration forces and angular force, which alter the area of damage considerably. We also have other types of changes, what are called phenotypes in humans, that are more susceptible to damage because of varying factors, including specific inflammatory reactions, metabolic capabilities, blood supplies, and many others. Ultimately, we have brain damage and a change in function of any number of functions in the brain, as we have previously alluded to. So in the next part of this series, we will discuss various diagnostic tests performed to show brain damage and changes in the subtypes previously stated. The third part of the series, I will discuss various treatments for all the types and subtypes of concussion, which make the most sense to give the best result. The fourth part of the series, we will actually talk a little bit about outcome assessment and how to look at treatment results with the best testing available. And we will take a quick look at CTE, or chronic traumatic encephalopathy, which people have a lot of fear concerning. I constantly have patients asking me, am I going to get the CTE? And we will go through the literature on this, because a lot of what people think is just not true. So have a great day, and we will see you for part 2.